All. So I welcome you all on behalf of Medicine Unit 1 to our CGR on the inflammatory flame from molecules to mammals and back, the dawn of a new era in medicine. So in this, we are going to share our experience and understanding which is evolving on the clinically significant disorders of immune regulation in adults. So this will be done under various headings. Dr. Bharadhan will introduce the topic and deal with the basics of immune response. Then that will be followed by disorders of immune dysregulation. Hyperinflammation will be presented by Dr. Charu. Inborn errors of immunity by Dr. Badnath. And autoinflammation in adults by Dr. Bhargavi. Finally, this summary will be given by Dr. Kavyanjali. So over to Dr. Bharadhan.
Thank you, sir. Welcome to the world of inflammation. Everyone knows the fact inflammation is the root cause of all major disease because inflammation is a universal response to stress. Inflammation is a biological response for immune system. Our understanding of inflammation starts with 4 cardinal signs, then led to 5 cardinal signs, then led to understanding of our immune system regarding innate and adaptive. Current understanding in inflammation goes up to cytokine regulation and receptor regulation. So this is the classification based on the cause. It consists of microbial inflammation, autoimmune inflammation, constitutive inflammation, metabolic inflammation, allergic inflammation, and physical inflammation. Now recent studies have showed even simple psychological stress for a chronic time can cause increased inflammation. Even short, rich fructose diet can increase the mitochondrial inflammation. Today's CGR we will be concentrating on autoimmune and constitutive inflammation. So whatever the type of inflammation follows the common pathway. First, it consists of 4 compartments. First compartment consists of inducer, which can be foreign antigen or self antigen, which leads to the stimulation of pattern recognition receptor, which leads to the stimulation of mediators, which include cytokine and chemokine, which act on the target tissue and cause organ dysfunction. So why we need to know about outcomes of inflammatory response? Because this decides the patient outcome. To understand this, we should know about the balance between anti-inflammatory mediators and pro-inflammatory mediators. Here you can see that even in normal individual, pro-inflammatory mediators are little bit higher than the anti-inflammatory mediators. There is a minimal tilt. But in case of autoimmunity and autoinflammation, tilt is getting bad. But in case of your hyperinflammation, tilt is getting even worse. Another most important thing to understand is balance. It is a dynamic balance because our immune system works on negative feedback mechanism. In case of autoimmunity and autoinflammation, balance is static, but tilt is more, but balance is not lost. But in case of hyperinflammation, balance is completely lost. So here comes the question, immune system is hero or villain? It's depend upon the situation. Immune system becomes hero when it is able to remove the infectious agent. Immune system become villain in case of autoimmune disorder and autoinflammation. So there is a 2 important crosstalk happens in the immune system. One it happens between innate immunity and adaptive immunity. So innate immunity communicates with adaptive immunity through by presenting antigen, and adaptive immunity secretes and cytokine, and it has a bidirectional communication between innate immunity and adaptive immunity. There is another crosstalk happens between Th1 and Th2. When Th1 is stimulated, interferon gamma is stimulated, which will lead to macrophage stimulation, but it also will inhibit indirectly Th2 proliferation. When Th2 is stimulated, it will stimulate B cell through interleukin 4 and 5, but it also will inhibit the Th1 through interleukin 10. So dysregulation of Th1 and Th2 lead to autoimmunity disorder. So immune dysregulation can happen in 3 ways. When innate immunity goes for dysregulation, 2 spectrums can happen. One is autoinflammatory disorder in adult, which can be in inflammosomopathies, interferonopathies, non-inflammasome related, which include rheolopathies. Hyperinflammation consists of macrophage activation syndrome, HLH, and cytokine release syndrome. Inborn errors of immunity, dysregulation of both innate and adaptive immunity dysregulation. Autoimmunity dysregulation, autoimmunity is more prone for adaptive dysregulation. Now we will jump into the mechanism of adaptive immunity. So now we will focus on the mechanism of autoimmunity. Tolerance is the ability of the immune system to remove the autoreactive T cells and B cells. When there is a failure of removal of autoreactive B cells and T cells, nothing but loss of central and peripheral tolerance. Central tolerance happens in bone marrow and thymus. Peripheral tolerance usually happens in lymphoid tissue, which leads to the tissue injury and autoimmunity. We all are familiar with autoimmunity disorder. Now we will focus our topic towards hyperinflammation. So hyperinflammation is a evolving concept which we started to learn during COVID times. We will see what is the definition of hyperinflammation. Hyperinflammation is a form of very severe inflammation with cytokine storm. To understand cytokine storm, we should understand the function of cytokine. Cytokine has two functions. One is autocrine function and paracrine function. So when macrophage is stimulated, when TNF alpha is released, it will act on itself and it will act on neighbor cell, that is called paracrine function. So it will be happening in a regulated manner. But in case of cytokine storm, it will lead to the dysregulation of autocrine and paracrine function. So what really happens is, because due to the dysregulation of your autocrine and paracrine and massive release of pro-inflammatory cytokine, it happens there is a nuclear chain of reaction which lead to the catastrophic event of the patient. So hyperinflammation is a very broad term which include majority of sepsis, and there are HLH variant which include macrophage activation syndrome, cytokine release syndrome, and infectious related HLH. Now we will try to understand, whenever body is exposed to any kind of stress, it can be non-infectious and infectious. So there will be inflammatory response, that is black circle, and followed by an anti-inflammatory response. So usually our body tries to do some kind of compensating anti-inflammatory response in sepsis and trauma. But in case of hyperinflammation, our body fails to produce adequate number of compensating anti-inflammatory response. Now we'll try to understand the basic. Our body can respond in two ways. It can move towards the circle or move away from the circle when immune dysregulation happens. But in case of hyperinflammation, body fails to do this, so that we give an exogenous immunosuppression to bring back the compensating anti-inflammatory response. So hyperinflammation condition present with common features like pancytopenia, liver dysfunction, coagulopathy, high serum ferritin, and inflammatory shock. What to call? It depends upon what patient condition is, which specialty is landed upon, whether patient have infection or not. In case of ICU, it will be sepsis and secondary HLH. In case of hematology, it will be primary HLH. In oncology, it will be cytokine release syndrome. In rheumatology, it will be macrophage activation syndrome. So now I would like to call Dr. Charu for discussion on HLH, which is the most common entity in hyperinflammation.
Thank you. So let's dive into our topic of HLH. So HLH stands for hemophagocytic lymphohistiocytosis. So decoding HLH. So what exactly is it? So it is an excessive activation of lymphocytes and macrophages, and hemophagocytosis means eating of RBCs, and lymphohistiocytosis means accumulation of mononuclear cells. So as we can see in this picture. So the name can be a little bit misleading because rare erythrophagocytosis can be seen in some conditions like after trauma, after sepsis, after blood transfusions, after malignancies. And also multiple studies have shown that hemophagocytosis is neither sensitive nor specific marker for HLH. And we can classify HLH based on two classification systems. So firstly, we'll classify it. Firstly, we have primary HLH. It can be classified into familial HLH as well as it can be associated with various genetic syndromes. Secondary HLH, which is more common in adults, can be due to triggering factors like infections, malignancies, autoimmune conditions, or other miscellaneous causes. Then we'll come on to the pathogenesis of HLH. So whenever an antigen enters our body, it is captured by antigen presenting cells like macrophages, and it is presented to Th helper cells via secretion of cytokines. So these helper T cells further secrete other cytokines like interferon gamma and other cytokines, which causes hyperactivation of macrophages. So these hyperactive macrophages in the normal human body are kept in check by NK cells via release of perforins and granzymes. But in a patient with HLH, this normal check mechanism is absent, and hence this is known as an immunodysregulatory syndrome. So currently there are various lacunae in existing knowledge about this very important entity. For example, it is very much underdiagnosed. There is a large chunk of the etiology which is unknown. There are pitfalls in the current diagnostic criteria. There are lack of good screening tools, lack of good outcome predictors. There is a very high mortality of this entity, and current treatment strategies already in place are extrapolated from the pediatric guidelines. And hence the result is a delay in diagnosis and treatment and a very high mortality. So we will be dealing with these aspects one by one, supplemented by our departmental data. So firstly, coming on to the fact that HLH is a disease entity which is concealed in common sight. And there have been very few studies in the global and in the Indian scenario, as we can see from this map. So this was a literature review published in 2014 in Lancet. And here we can see that the maximum amount of studies have been in Eastern Asian countries, and there have been very less amount of publications in the Indian scenario. So this is in stark contrast with what we see in our hospital life. And here we can see from our data that an observational prospective study which was conducted in our department showed that 43% of the HLH, of the critically ill patients coming with fever and bicytopenia were diagnosed with HLH. So in recent years, we are seeing a rising number of patients diagnosed as HLH. And this can be seen from this picture, in which we see that there is a rising amount of publications in the recent years. So a high index of suspicion is needed in critically ill patients to diagnose HLH. Then coming on to the etiology of HLH. So global data shows that the maximum number of patients were diagnosed with infections followed by malignancies, and this is replicated in our departmental data as well. But here I would like to highlight the fact that that a majority of patients also have unknown etiology as the cause of HLH, which, as I will show later in the later slides, has a very high mortality as well. Then coming on to the current diagnostic criteria. So the current diagnostic criteria includes either a molecular diagnosis or fulfillment of 5 out of these 8 separate parameters. But there are various pitfalls of this diagnostic criteria. So firstly, coming on to the cutoff of ferritin at 500. So is this cutoff really adequate? So in our study, in which we had measured various parameters of the diagnostic criteria, we can see that hyperferritinemia So here we can see that in our data, we saw that at a cutoff of 500, there was a maximum, it was found to be in a very high number of HLH patients as well as non-HLH patients. So hence proving that this cutoff is very non-specific. So similarly, in various studies, we've seen that conditions with an elevated ferritin of as high as 50,000 can be seen in various other conditions as well. And hence, various studies have shown that although higher cutoffs have better specificity, but there is no ferritin cutoff value above which it is specific for HLH. And negative predictive value of a normal HLH is quite high. And so we can also see that hemophagocytosis and parameters like low NK cell activity, even though they are very good markers of HLH, we were not able to perform these tests in a majority of our patients due to logistical issues. So ferritin and cytopenias are less specific. NK cell functions and interleukin 2 receptors are difficult to get. Fibrinogen levels are difficult to interpret, and demonstration of HLH, as told earlier, is neither sensitive nor specific. Then coming on to some of the good screening tools. So there are newer scores in place. For example, the H score, which is a score which is available in various mobile applications like MDCalc, in which we calculate on the basis of 9 criteria. It does not utilize functions like NK cell functions and soluble CD25 receptors. It has a high sensitivity but a poor specificity, which is reflected in our departmental data. Similarly, scores like the bone marrow score is also in place, which is available, which has a good sensitivity but a poor specificity, again reflected in our departmental data. Then coming on to lack of outcome predictors. So for this, we have a departmental study in which we have conducted the study on, it was an ambispective study conducted on 50 HLH patients, in which we saw that at admission, the mean H score did not have statistical significance in predicting mortality outcome. A higher SOFA score at the time of diagnosis was associated with a poor prognosis, and mortality was lesser in HLH due to infectious causes and higher in HLH due to unknown causes. And trends of various biochemical and hematological parameters were followed during the course of the hospital stay. So studying the role of ferritin as a predictor for mortality, at a cutoff of 500 to 600, it had a very low specificity. However, as we moved upward to the cutoff of 5,000 to 10,000, it showed a higher odds ratio for prediction of mortality. And similarly, other markers like rising prothrombin time, falling albumin, rising triglycerides, falling hemoglobin, and falling platelet trends at day 3 and day 7 they showed that they were good predictors of mortality for HLH patients. So, in a nutshell, we have good prognostic factors like infections as etiology, and bad prognostic factors were highlighted before as the various hematological and biochemical parameters, along with unknown etiology. And the ones which are highlighted in red have been reflected in the global data. Then, coming on to the fact that this is an entity of high mortality. So, mortality rates from our departmental data show that it ranged between 41 to 44%. And the global data showed that it ranged between 20 to 88%. Then coming on briefly to the treatment strategies. So the treatment strategy is three-pronged. It includes treating the inciting factor, giving supportive care, and giving immunomodulation. So taking a closer look, so we can see that whenever a patient comes with HLH, if the patient is stable, we will identify and treat the triggering factors. However, if the patient is unstable, we will first give empirical immunomodulation, including steroids, anakinra, and IVIG. Anakinra, however, is not very much available in our settings. Then we will look at the etiology and treat the triggering factors and give the therapy according to that. So if the patient has an underlying infection, we will give suitable antimicrobials. If the patient has an malignancies, we will give pre-phase chemotherapy, topocyte, etc. If the patient has an autoimmune or inflammatory condition, we will give cyclosporin A, anakinra, high-dose steroids. And if the patient has a drug-induced etiology, we will give tocilizumab, steroids, etc. However, if there is no response to these therapies, we will turn to salvage therapies which are already in place, and we will give supportive care at each of these individual steps. So coming on to the departmental work, so in our studies, the maximum amount of patients received steroids and also received other immunomodulatory agents sparingly. The median day of steroid and etoposide initiation was 5 and 14 respectively. However, in our study, majority of the patients had infective etiologies, and hence there was a delay in initiation of these immunosuppressive agents. So coming on to the last aspect of interplay between sepsis and HLH. So sepsis patients are usually present in a delicate balance between infections and a controlled inflammatory response. When this balance is maintained, the clinical sepsis is present without HLH. However, when this balance is disrupted, the sepsis HLH overlap comes into play. So a sepsis patient will have tissue damage releasing various cytokines. So these cytokines will stimulate macrophages and dendritic cells. And we already know that NK cells keep a check on these macrophages and dendritic cells. However, the release of this interleukin 10 and interleukin 6 will inhibit the NK cells, causing a hyperactivation of macrophages. These dendritic cells also cause activation of macrophages by release of interferon gamma. They cause activation of inflammasomes, causing a release of various cytokines. And all of this leads to a cytokine storm as well as hepatobiliary dysfunction and DIC. So all of this is important because we need to identify septic shock patients who portray these early biomarkers of HLH. And this is also important because this pathway shows us the newer therapeutic modalities which are currently underway, which is the anti-interferon gamma antibodies, anti-interleukin 18, anti-interleukin 1 beta therapies. So this leads us to our departmental work, which was a prospective observational study done in admitted patients with sepsis who subsequently developed hospital-acquired infections. And the percentage of CD3 positive T cells expressing PD1 and CD14 positive monocytes expressing PDL1 were compared between survivors and non-survivors. However, in our study, we could not find any statistical difference between the two groups. But this study was done in the premise of previous studies, which showed that an increased expression of PD1 related molecules had an association with mortality. And this paves way to the newer therapeutic modalities of the role of PD1 inhibitors. So I would like to sum up by saying that HLH is an immunodysregulatory entity. It is very much underdiagnosed, has a high mortality. Secondary HLH is more common in adults. Hemophagocytosis is neither sensitive nor specific. We need a very aggressive treatment strategy to deal with this entity. And in the future, we need to address the lacunae which are already present in our knowledge. And also that newer diagnostic modalities and newer therapeutic strategies are already in play and they are underway. So now I would like to hand over to Dr. Bardhan sir for taking forward the discussion.
Now we will shift the gears toward inborn error of immunity. So inborn error of immunity consists of both dysregulation of innate and adaptive immunity dysregulation. In innate immunity, it can be phagocytic defect or complement defect. Complement defect can be C1 esterase deficiency. In case of phagocytic defect, it can be chronic granulomatous disease or leukocyte addition defect. In case of adaptive immunity, it can be T cell mediated. Examples are ataxia telangiectasia. In case of B cell defect, it can be selective IgA deficiency or combined variable immunodeficiency. Now I would like to call Dr. Vedanath for discussion on our departmental work on adult inborn error of immunity.
So, inborn errors of immunity are nearly 500 inherited disorders, often causing impairment in normal immune development and function. So, these has been categorized into 10 categories by International Union of Immunological Societies. So, these defects are according to the arms of immunity that is being affected. If we see the category 1 and 2 are affected acquired immunity, those are immunodeficiencies affecting combined immunodeficiencies, and if it is affecting only B cell, that causing predominantly antibody deficiency. And similarly in the innate immunity, if it is affecting phagocytes, that is the disorder of phagocyte number, function, or both, and if it is affecting complement, then complement deficiency. These 9 categories are till the each arms being affected. The 10th category is phenocopies of inborn errors of immunity. So these are the disorders that mimic inborn errors of immunity, but usually either they have somatic mutation or the patient has developed antibodies. If we see the number of genes being discovered in last 20 years only, there is exponential growth in the number of genes being discovered. In last 2 years only, 55 novel genes has been discovered in this IAI category. So RII is rare disorder. If we go to the epidemiology, this varies. The number of reported cases are between 0.5 per lakh to 0.15 per lakh population. In India, it is on the lower side, mostly because we are underreporting these cases. Individually, IIs are rare, but if we see prevalence of CVID, that is 4 per lakh individuals, and that is similar to the prevalence of common disorders like myasthenia or ALS. Estimated combined prevalence of these disorders are 1 to 5 per thousand, so that is quite common. We have to look for these disorders. Coming to the specific category of these disorders, the most common is predominantly antibody deficiencies, followed by combined immunodeficiencies, either associated with syndromic features or no. So these 3 constitute the major portion of the IEI disorders. The second question is, are IEI pediatric diseases? If we see the prevalence in adults, this is 2011 data, which is 36% cases were diagnosed in the age group of more than 20 years. But down the years, the more and more number of cases are being diagnosed in adults. We can see in the recent US ID network data, like 83% of the patient has been diagnosed in more than 18 years of age. So these disorders are being more recognized and diagnosed in adult now as compared to the pediatric patients. Coming to our departmental work, in last 2 years, we have around 22 cases representing the entire spectrum of IEI disorders that we can see. To understand the clinical presentation of these IEI disorders, I'll go briefly through the various cases that we have diagnosed and managed, and after that we will understand how they usually present. Coming to case 1, she is 29-year-old female with type 1 diabetes mellitus. Initially, she presented with fever and generalized weakness. She was diagnosed with tuberculosis, basis of lymphadenopathy, but she didn't respond, and further ATT was discontinued, and FNA also shows only reactive changes. So further she was extensively evaluated at our department, which shows bicytopenia with lymphocytosis, with reticulocytosis, and direct antiglobulin test negative hemolytic anemia with hypergammaglobulinemia. Other autoimmune profiles were negative, and further imaging study shows hepatosplenomegaly with lymphadenopathy, which was also FDG avid on PET scan. So thus we further evaluated on the lines of lymphoproliferative disorders, and biopsies were done. Lymph node shows reactive follicular changes, bone marrow shows multiple lymphoid aggregates. So on suspicion of autoimmune lymphoproliferative syndrome, we sent flow cytometry for double negative T cells, which was raised. And to further evaluate, we also sent ALPS gene panel, which comes normal. but this can be present in 20 to 30% of the patients in ALPS, because either they are genetically undefined or there is somatic mutation. So thus making our final diagnosis of ALPS with chronic lymphoproliferation and other autoimmune features, and she was discharged on Vicelone. Further MMF was added and she is doing quite well for last 1.5 years. If we see second case, she is 38-year-old married female. Initially, she was diagnosed with hepatitis B, then celiac disease, disseminated tuberculosis. She was given MPS pulse for polymyositis. After that, she has florid infections. And again, she was presented to our AIIMS. On evaluation, she found to be lymphopenia with reduced subsets of B cells, CD4 T cells, and NK cells. Thus, making on further evaluation, she was also diagnosed with autoimmune hepatitis and other various infections. So, considering this presentation, we sent the genetic analysis, which augmented in our diagnosis and shows JAK3 mutation, thus making our final diagnosis of adult onset severe combined immunodeficiency with infectious as well as autoimmune manifestations. If we see case 3, he is 16-year-old male, presented with diarrhea, recurrent sinopulmonary infection since 3 years of age, with other symptoms of sweat, unable to sweat even under extreme hot condition, and difficulty in getting up from the sitting position. So further he was evaluated on imaging, only shows lymphadenopathy with fibrobronchiectatic changes. On further evaluation, he was having pure motor axonal neuropathy, hypohidrosis was confirmed, and considering this presentation, we further sent genetic analysis, and which shows STIM1 mutation, thus making our final diagnosis of combined immunodeficiency with associated syndromic features. The syndromic features here were myopathy and hypohidrosis. So after seeing these 3 cases, we can see that IIIMS doesn't only present with infections. They have a component of autoimmunity and autoinflammation as well as lymphoproliferation as the predominant features. Along with that, there are other features also like ectodermal dysplasia, neurological abnormalities, etc. So just to summarize the clinical presentation, these are the broad categories. These are not the watertight compartments, and every disease is present with overlapping features from each of these categories. For example, defect in innate and intrinsic and innate immunity, mostly they present with manifestation in forms of infections. But if we see diseases of immune dysregulation and autoimmunity, they present mainly with manifestation in autoimmunity or lymphoproliferation. So now coming to the specific types of disorders that we have managed in our department, in category of predominantly antibody deficiencies, we have various cases, out of which I have shown here CVID and hyper IgM cases. In here the interesting thing to note, like 3 of our CVID cases has presented with chronic diarrhea. But if we see the etiology, in one it was giardiasis, the other one it was IBD, and the third one it was tuberculosis. So patient can present with similar etiology and similar presentation, but will have a different etiology. Thus implicating their different approach in treating these patients. One of the cases also presented with immune mediated encephalitis and granulomatous lymphocytic ILD. This case was managed with the help of our department of neurology, and he is doing well right now. In hyper IgM case, the patient had presented with atopic eczema and bronchiectasis. Coming to the second category, that is defect in intrinsic and innate immunity. So the common examples are MSMD and CARD9. Out of the various cases that we have diagnosed of MSMD, so MSMD is like Mendelian susceptibility to mycobacterial disorders. It doesn't mean that they only present with mycobacterium, but they have also predilection for the dimorphic fungi. In one of our cases also, the patient has presented with histoplasmosis. CARD9 deficiency, patients have predilection for having invasive fungal infections. In our case, patient has presented with Cladophiloflora bantiana brain abscess, although he's come to illness. Coming to the defect of phagocyte number and function, in this category, one of the common disorder is chronic granulomatous disease. The various cases that we have managed, so the patients having CGD have a predisposition towards the infection by the catalase positive organisms. Examples, bacteria is catalase positive and all fungus are catalase positive. So they usually present with catalase positive organisms. In our cases, it was presented with MRSA, and the second case has presented with mucormycosis. Coming to the next category, that is CID with associated syndromic features. So here we have diagnosed cases of hyper IgE syndrome or STIM1 deficiencies that I have discussed. Usually hyper IgE syndrome patients present with dysmorphic features, but it was unusual in our case. He doesn't have any dysmorphic feature, but he presented with disseminated aspergillus infection and has eosinophilia, which further led to the further evaluation, and we found STAT3 deficiency, thus making diagnosis of hyper IgE syndrome. Coming to the category of disease of immune dysregulation, the common examples are autoimmune lymphoproliferative disorders. One of the case was diagnosed and she was managed very well and she was in follow-up, but she defaulted on treatment, and later on she presented to our department with flare, and later in the course of treatment she has come to death, she has come to her illness. But on postmortem diagnosis, likely she had HLH. She died due to HLH. So the important point here to notice is that after diagnosing these cases, we have to maintain a regular follow-up and treat various manifestations that can occur in course of disorders. Coming to the autoinflammatory disorders, so there will be detailed discussion on it. Complement deficiencies usually presents with early onset SLE, and bone marrow failure symptoms usually present with dysmorphic features and symptoms of bone marrow failure. Just briefly regarding the broad concept of primary immunodeficiency and the inborn errors of immunity. So primary immunodeficiency is a broader concept in which if there is inherited mutation, then we put it under inborn errors of immunity. But if a patient has either somatic mutation or patient has developed antibodies, then it is considered out of the category of inborn errors of immunity. The common examples are IgA deficiency, which is the most common immunodeficiency a patient can have, or most common prevalence, but usually they are asymptomatic, so they do not seek any medical attention. Other examples are Good syndrome, idiopathic CD4 lymphopenia, CVID having no monogenic mutation. So in idiopathic CD4 lymphopenia, these patients usually present with opportunistic infections. In our cases, they have presented with NTM, nocardia, cryptococcosis, and cryptosporidiosis. Just briefly regarding the diagnosis and treatment. In diagnosis, there are two major categories of investigations that we can do. First is the evaluation of immune system. These tests are being done in our Department of Transplant Immunology and Immunogenetics. And the second is genetic testing. But it is not always feasible to do genetic testing in all of the patients, and also it is very costly. So, and similarly, we can see in the genetic test being done all around the world in cases of IAI. So, only less than 50% of the cases have genetic diagnosis. In our cases, we have done genetic testing in 60% of the cases, mostly because there are various projects that are undergoing in our department. The treatment, it usually consists of 3 arms. One is to prevent infection by isolation measures or IVIG. The second domain is to manage complications. And the third one is immune reconstitution by hematopoietic cell transplantation or gene therapy. So I'll call Dr. Bardhan for taking further the discussion.
Now we will shift the gear toward autoinflammation. So systemic autoinflammatory disorder, to define in one word, it is sterile inflammation. Inflammation in the absence of infection, autoimmunity, and malignancy. It also involves multi-system involvement. It can present with dermatitis, osteomyelitis, but everything will be sterile. It is not just a pediatric disease, but it can also present in adult, because we humans are more prone for somatic mutation. So first it was described as hereditary periodic fever syndrome. Now, few decades back, Dr. Daniel Kessner, father of autoinflammatory disorder, named as autoinflammation because the classical presentation of periodic fever was not there. He also states that autoinflammatory disorder in humans will be inevitable. So classification of systemic autoinflammatory divided into monogenic, which consists of inflammosomopathies, interferonopathies, non-inflammasome related disorder, which include rheolopathies, then polygenic systemic autoinflammatory disorder, which include crystallopathy and other things. Then another important thing is overlap syndrome, autoimmunity and autoinflammatory overlap syndrome. We have seen about the crosstalk between innate and adaptive immunity. In this, usually interleukin 1 is responsible for overlap syndrome. So it is impossible to discuss all systemic autoinflammatory disorder in one case. I know everyone head is spinning, even my head is spinning, but we have covered inflammatory pathway, we'll try to link it. So inducer in systemic autoinflammatory disorder is self-antigen, which will lead to the stimulation of NLR complex, which will lead to the stimulation of inflammasome, and which will lead to interleukin 1 and TNF alpha. In case of intracellular RNA or DNA, which will lead to the stimulation of interferon pathway, which will lead to interferon gamma. So any dysregulation in sensor like NLR will give to inflammosomopathies. In case of dysregulation in DNA sensor or RNA sensor will lead to interferonopathies. Any dysregulation in IL-1 and TNF alpha signaling and receptor can happen. Now we can see that the dysregulation in inflammasome, especially like pyrine dysregulation, can lead to familial Mediterranean fever. In non-inflammosomopathies, the proteasome dysregulation can lead to proteasome associated autoinflammatory disorders, and dysregulation of TNF alpha receptor can lead to TRAPS. So here you can see that it is interferonopathy, usually an intracellular missignaling of DNA. In case of it will lead to sting associated vasculopathy with onset in infancy. In case of DNA missensing can lead to AGS syndrome. Rheolopathy is nothing but dysregulation of nuclear kappa factor, which will lead to haploinsufficiency A20. Now I would like to call Dr. Bhargavi to give insight on Departmental of Cohort of Autoinflammatory Disorder.
So now I'll be giving a snapshot of few interesting cases from our departmental cohort of autoinflammatory disorders. So without much delay, let's delve into the first case. He was a 69-year-old male who had fever, dry cough, weight loss. He was found to have right pleural effusion, for which he was started on ATT in an outside hospital. However, there was no improvement. After 5 months, he developed an episode of unprovoked DVT in his left lower limb, followed by DVT in his right upper limb, and an episode of subglottic edema, for which he required ICU care. When he presented to us, we found multiple skin nodules on his body. He had right-sided facial swelling, and lab investigations showed macrocytic anemia and raised inflammatory markers. So with this background, we kept a broad differential diagnosis of infection versus malignancy. However, extensive evaluation for the same did not reveal anything significant. So what are we missing in this case? So when we have a patient who serum free light chain acids. So when we have a patient who presents with a constellation of inflammatory features and we've ruled out infection and malignancy, naturally the next group of disorders that come to our mind are the systemic autoimmune rheumatic diseases, which are caused due to adaptive immune system activation. But we need to remember that we have another group of disorders caused due to innate immune system dysregulation, where the key players are neutrophils and macrophages releasing cytokines. These disorders are the systemic autoinflammatory disorders. In our patient, the autoimmune profile was also negative, so we kept a suspicion of autoinflammatory disorder, and this suspicion was further strengthened by this bone marrow finding of multiple vacuolations in the myeloid precursors. So we sent a targeted genetic testing panel which showed a mutation in UBA1 gene, and hence we made a diagnosis of Vex's syndrome. He was started on oral corticosteroids and he's doing well so far. So let's move on to before we move on to our second case, let's see in brief about Vex's syndrome. This was very recently described in the year 2020 by Beck et al. Using a genotype-driven approach. So majority of these patients were found to have inflammatory symptoms and hematological abnormalities like macrocytic anemia, and 100% of these patients had vacuolations in the myeloid or the erythroid precursors, and hence they named it the Vex's syndrome, where V stands for vacuoles as described. E1 is the E1 ubiquitin activating enzyme, which is coded by the UBA1 gene on the X chromosome. A stands for the autoinflammatory features and S stands for somatic, indicating that these mutations are acquired later on in life. Subsequent studies have shown that these patients are predisposed to hematological malignancies, especially myelodysplastic syndrome. So let's move on to our second case. She was a 28-year-old female who had fever, GI symptoms, oral ulcers, past history of pulmonary tuberculosis, and incidentally was detected to have bilateral hydroureteronephrosis. An FDG PET scan done showed multiple FDG avid lung infiltrates and FDG avid thickening in her neck vessels and also in her retroperitoneal vessels. So we kept a broad differential diagnosis of disseminated TB versus IgG4 disease versus Behçet versus a histiocytic disorder. She was started on ATT and steroids and discharged. But she came after 3 months with persistent symptoms despite treatment and loss of weight and loss of appetite. And now she had 3 grams of albuminuria. She was planned for further evaluation, but she had to be discharged on request. So after discharge, she stopped steroids on her own and she came back after 3 months, now with recurrent diarrhea and generalized body swelling, and she had 6 grams of albuminuria. We repeated an FDG PET scan, which showed an increase in the lung infiltrates. A subsequent renal and sigmoid biopsy done showed AA amyloidosis. So since this patient had multisystemic inflammation and amyloidosis, we had a suspicion of autoinflammatory syndrome. She was started on methylprednisolone and was being planned for TNF inhibitors. And now in her third admission, on repeated probing, she gave history of febrile episodes on and off since the past 10 years, contrary to what she had told initially, and this further increased our suspicion of autoinflammatory syndrome. But unfortunately, before the genetic testing panel report was available, she succumbed to severe sepsis. The final report showed a mutation in TNF AIP3 gene, making a diagnosis of haploinsufficiency A20. So this syndrome is otherwise called the familial Behçet-like syndrome. It is an NF-kappa beta mediated monogenic autoinflammatory syndrome. The hallmark features include early onset recurrent oral, genital ulcers and gastrointestinal symptoms. It was described very first in 2016 in pediatric patients. However, a subsequent study done in 2018 by Florence et al. In 16 patients showed that 4 of these patients actually had adult onset symptoms. And if we take a closer look at the table, majority of the patients who had childhood onset symptoms ultimately got diagnosed in adulthood. And hence, this monogenic autoinflammatory syndrome becomes relevant for adult physicians as well. So with this, let's move on to our third case. She was a 27-year-old female in her 23rd week of gestation who presented with fever, rash, polyarthralgia. She had neutrophilic leukocytosis, raised inflammatory markers. We had initial differentials of systemic autoimmune rheumatic disease versus adult onset Still's disease. And she was fitting well into this Yamaguchi criteria for AOST. So the most important part of the criteria is this exclusion component. Infection, malignancy, and other rheumatic diseases have to be ruled out before we make a diagnosis of AOST. So our patient was diagnosed with adult onset Still's disease, started on steroids, and she was discharged on 31st of August. She came back after 2.5 months for safe confinement. She delivered a healthy baby, but postpartum she started to spike high-grade fever. Retained products of conception was ruled out. She was started on antibiotics, but her fever did not respond, and hence she was transferred to our department for further management. So when we received the patient, she was found to have cytopenias and raised inflammatory markers. So keeping a background of AOSD, a possibility of macrophage activation syndrome was kept, for which she was treated with methylprednisolone, IVIG, and a course of cyclosporin, following which she became afebrile, her cytopenias improved, and her inflammatory markers settled. But now she developed new onset respiratory distress, and on the X-ray we found a miliary pattern. So she was diagnosed with miliary tuberculosis, ATT was started, and now because she developed tuberculosis, we had to decrease her immunosuppression. Now, as we decrease her immunosuppression, again she started to spike fever. There was recurrence of cytopenias. Her ferritin shot to 1 lakh, and she had new onset hypotension. So, after ruling out all the other possibilities of shock, we kept the possibility of hyperinflammatory shock, for which we gave her multiple pulses of methylprednisolone, another course of IVIG and etoposide, following which she became afebrile, but now she had persistent cytopenias. We suspected etoposide-induced cytopenias, and because it was of grade 4, we discontinued it, gave her filgastrip, and ultimately, after all these, she finally improved. She was put on tocilizumab maintenance and discharged. So the diagnosis was adult onset Still's disease with postpartum refractory mass, and she is currently doing well so far. So this was one of the many challenging cases that we have managed. So if we look at this case, on one side we had the hyperinflammation due to the macrophage activation syndrome, And when we were trying to tackle it with immunosuppression, new issues like miliary tuberculosis and drug-induced side effects like cytopenias came up, which were promptly recognized and managed. So through this case, we want to emphasize that a close watch for infection and drug-induced side effects is vital when we are aggressively immunosuppressing a patient. So with this, let's move on to our fourth case. She was a 25-year-old female with fever, weight loss, vomiting for 2 years, had recurrent ear pain, redness and swelling. Multiple abdominal imagings done outside showed liver and splenic abscesses. However, microbiological isolation was not possible. She was treated with multiple courses of antibiotics, including cover for atypical organisms. She also developed bilateral sensory neural hearing loss due to gentamicin, resulting in a right dead ear. So when she came, we did an FDG PET scan, which showed multiple lesions in her liver and spleen, which were FDG avid. We did extensive infection and autoimmune workup. Everything turned out to be non-contributory. So we went back and reviewed the literature, and we found similar patients being reported who had intra-abdominal abscesses. A majority of these patients had associated inflammatory conditions elsewhere, frequent ones being relapsing polychondritis, inflammatory bowel disease. These patients had raised inflammatory markers. Extensive infection workup did not reveal anything significant. And when it came to treatment, these patients did not respond to antibiotics, but they responded dramatically to corticosteroids. And the unifying diagnosis was aseptic abscess syndrome, which is otherwise called the corticosteroid responsive sterile abscess syndrome. So the final diagnosis in our patient was aseptic abscess syndrome with relapsing polychondritis. She was started on steroids followed by methotrexate. She improved symptomatically. This is her PET scan done after 6 months, which shows complete resolution of the liver and the splenic lesions. So in this presentation, we have seen 4 interesting autoinflammatory cases. However, the story does not end here. We have an expanding cohort of autoinflammatory cases across a wide spectrum, but due to paucity of time, we could not present the details of these patients. So in the end, I would like to say that at the end of the day, these syndromes are relatively rare, and so we should not lose sight of the forest for the trees. Let's see with one last example of a 17-year-old female who presented with episodic bone pain since 6 months, insignificant weight loss, had raised inflammatory markers, and she had evidence of bone marrow edema on the MRI spine done outside. So she was diagnosed as a case of chronic recurrent multifocal osteomyelitis, which is an autoinflammatory syndrome, in an outside hospital. So when she came to us, we extensively evaluated her MRI. Whole body was suggestive of infiltration of the axial and the appendicular skeleton. A subsequent peripheral smear and a bone marrow examination showed blasts, and it was actually a case of acute leukemia. So what initially was diagnosed as a case of CRMO, an autoinflammatory syndrome, actually turned out to be a high-grade malignancy. So through all these cases, I think it is clear that a timely suspicion of autoinflammatory syndrome is important, but at the same time, we have to remember that we have to actively rule out common masqueraders like infection, autoimmune rheumatic diseases, and malignancy before we brand a diagnosis of autoinflammatory syndrome. So finally, we've come full circle after discussing all these immune dysregulatory disorders, and it is fairly clear that dysregulated inflammation is at the root of most of the major diseases. With this, I invite Dr. Kavyanjali to give the summary.
So there is rising prevalence of disorders of inborn errors of immunity, autoinflammatory syndromes as well as HLH. And these are not just pediatric disorders, these are also seen in adult population commonly. So when to suspect these disorders? A disorder of inborn error of immunity need to be suspected when patient presents with recurrent infections. Apart from that, patient can have features of autoimmunity or lymphoproliferation or syndromic features as discussed earlier. First, we need to evaluate the immune system. If found non-contributory, genetic testing might be helpful. Autoinflammatory syndrome should be suspected when patient present with features of sterile inflammation. We need to identify a pattern. If symptoms do not fit into a particular pattern, genetic testing might be helpful. We have various departmental projects running to aid in genetic testing. HLH should be suspected in a critically ill patient who has persistent fever spike, worsening cytopenias or ganomegaly. We need to evaluate extensively for the underlying etiology, and simultaneously we need to send confirmatory workup also. The treatment will depend upon the condition which is diagnosed. For disorder of inborn error of immunity, we need to prevent infection, manage complication and immune reconstitution. Patient with autoinflammatory syndrome need immunosuppression. Patient with HLH, we need to treat the underlying etiology as well as need immunosuppression if the patient worsens. Now I would like to call Dr. Siddharth Jain, Faculty Department of Medicine, for concluding the CGR.
Thank you, Kavyanjali. As we come to the close of this CGR, I would want to drill home a few key concepts. Firstly, the boundaries between infection and non-infectious inflammation are slowly getting blurred, and these two often coexist. Managing these patients is a challenge, the outcomes being universally poor. Immunosuppression in the setting of active infection, which was formerly frowned upon, is slowly becoming more than just an exception. The expanding options in our therapeutic armamentarium, including the cytokine targeted therapies like anakinra, offer good hope in this dismal sort of a situation. However, it is important to exert caution as far as the side effects and complications of these therapies are concerned. Knowing when to go all out and knowing when to hold back our guns, the nuanced, personalized decision that needs expertise and ultimately has a direct bearing on the patient outcomes. Secondly, it is very clear that inflammation is the central unifying concept, which is very evident if we see the mainstreaming. So, immunomodulation is coming as a mainstream therapy in the changing treatment landscape of as diverse disorders as atherosclerosis on one side to severe acute pancreatitis on the other side. Thirdly, our research work clearly invokes a strong multidisciplinary collaborative aspect. So there are patients of PID who are floating around diagnosed as ITPs or as bronchiectasis or as granulomatous lymphadenopathy, splenomegaly. There are cases of autoinflammatory syndromes which are roaming around without a diagnosis despite extensive evaluation. And unless we train our minds to look at the soft clinical signs, to interpret those subtle laboratory anomalies that suggest a multi-system involvement, we'll never be able to have a unifying diagnosis, which is absolutely mandatory to improve treatment outcomes in these patients. We in the department are maintaining a cohort or a registry of such patients, and we have research funding that facilitates deep genetic analysis that is often required in these undiagnosed cases. And the various departments can leverage this facility for the difficult cases that they might commonly encounter. I would fail in my duty if I don't say that despite all of these efforts, a lot of these patients still remain undiagnosed. And it is here that the role of phenotypic clustering, deep genotype diving, periodic clinical re-evaluation becomes of quintessential importance. And even despite that, if you're not able to make a diagnosis, there are often times where we'll have to give empirical immunomodulatory therapies, but they are not empirical as in hit and trial. So we have to see what is the likely pathway involved and then give targeted immunomodulatory therapy. We have, to be very honest, we have just scratched the surface in this CGR. These are so complicated topics, so intricate, so balanced, so nuanced. But because of the technicalities, because of the complexities, we had to ultimately get down to the level so that everybody relates to that. So we have scratched the surface, but we have nonetheless introduced a few very novel concepts. Specifically that one we mentioned of hyperinflammatory shock, which we have successfully managed. We have quite a few patients which we have managed shock with pulses of methylprednisolone, a very radical concept which is almost at a cutting edge frontier because it hasn't even landed up into the published scientific literature yet. Very beautiful, very beautiful. Finally, before I conclude, I would like to re-invoke the title with which we started, because although it did garner some interest, but it did raise a few eyebrows as well. So ladies and gentlemen, molecules form the building blocks of everything, living and non-living. And in this burning flame of inflammation in which many of us are burning, it is about time that we go back to our molecules and try to develop a strong immunological understanding of the pathways, cytokines, molecular mediators that drive the pathogenesis of these disorders, because that is what ultimately will pave the way for targeted molecular therapeutics, discovery of new diseases, and thus ushering in the dawn of the new era of medicine. I think I'd like to conclude with that, and I'll open the floor for questions and expert comments from the house. Thank you. from its experiences.
Yeah, very good presentation. And our education team. One comment asking one case is very good. Where you started, people also going on. You mentioned so if you also can underline there, like, the- anybody else?
Thank you, sir. Actually, it was discussed extensively, and we do encounter such kind of autoimmune disorders. Nowadays, there is advancement in the diagnosis as well as the therapeutics. So, we are talking about the targeted therapy as well as the genetic testing. So, coming time, we will be able to know exact pathophysiology, which cytokine they are giving, which cytokine giving this mechanism, which antibody is giving this mechanism. Third thing, my side is nowadays we are moving toward the integrated pathology. Similarly, autoinflammatory disease, where we are looking behind the pathophysiology, this is immunity mediated and difficult to diagnose in such a scenario where there is infection and other immune systems are not working. Recently, I have encountered a patient of the pain was on the knee, and that was sugar arthritis. It is kind of autoinflammatory, where the intense inflammation lead to first kind of condition. And other patient from the ENT, where there was subrotic edema, and she was traumatized 3 or 4 times, because every time she leads to the spider and dyspnea, she has to traumatized. So ultimately, she was diagnosed to have relapsing pulmonaritis without any involvement of the ear artery. So that was diagnosed based on the PET scan. So you have to be the careful and you have to be the sensitized regarding diagnosis, and till you get diagnosis, you know the job, you are thinking regarding that. So communication.
The comments from Mr. Maxim. Suppose it is difficult to diagnose them. We can see a patient and then we don't know. We don't know the phenotype. Sometimes patients remain undiagnosed. We have some parameters and then we come to you and we ask you what it is, this is infection or this malignancy or this information.
Yes, sir. So as far as the secondary causes of infection and malignancy, we can guide you there. And the sites of involvement, response to therapy, and also now with guided biopsy, we can target these sites if they're accessible. That's how we can help you out.
Somebody?
So as Siddharth rightly said, this is a new frontier. So these diseases have already been there. It is only that we were not able to diagnose it. Now we have some modalities to understand what these diseases are. But if we talk about autoinflammation, probably we are just at A now. Our understanding is limited to A. There's lot more that we need to understand. Much of research is required in this area. And there are not many patients these days who are coming with such a, we are not able to think, suspect, and attempting diagnosis. Patients who are having unexplained inflammation, absence of an infection. And many a times, all these workup do turn up negative because we do not have the sufficient diagnostic armamentarium right now. We do not have the understanding. So these are the challenging areas, the new frontier. So basically, what is your duty now? If you encounter a patient with infections, with features of autoimmunity, do think of this ability and then the workup can follow. So our job is to suspect autoinflammation, infection, think of this condition. Things subsequently will follow.
So what is the single message we wanted to convey today?
Continuous exploration. Keep continuous exploration.
It is infection, information or intensity. If you don't think, you don't treat, patient will die. If you shock, hyperinflammatory shock, patient will not wait. Because it is where the which I have been thinking. Probably I have got answers today because of the appearance of urban and the residents, the way they have, Dr. Siddhartha, the way they have conceptualized the thing. Adel, I don't know whether there is also conceptualized. It is not easy. Conceptualize how to handle, when to attack, whether to be patient stable, you have to keep on follow. Patient is hyper inflammatory in front of you, and then you are seeing the program, you are seeing the CRP, you are seeing the ferritin, you have to treat. And many times, the message which I am trying to say, we have to think about those patients, how to handle them, and then how to handle them. Otherwise, we are not able to treat. So it is not easy to get it. Sometimes your clinical judgment will also play. Otherwise, the infection or inflammation will lead to death. If you don't know, we want them to be treated and fast. Other question is there. So again, it is not rheumatology, it is not hematology, it is not pathology. Name it. It is not infection. It is not inflammation. We don't know what it is. So it's all going together in a particular patient. Sometimes anti-negative hospital you have to treat. So you have to understand the immunology as it has been nicely said. Then we have to look at the gene expression, pathways, because I think we are weak in this. When HIV came, it was all immunodeficiency and infection, bit of inflammation here or there. Infection related inflammation. Then HLH concept came, we had to treat many patients. Many patients got sick. You see the mortality is still about a year ago. Because we are delaying in diagnosis, we are delaying in thinking, we are delaying in treating. So, but it is there in front of my eyes, how can I wait? I can't wait for tests to come. We have ferritin, and that time ferritin will come after a week. But today, so that was very aggressive. And then came COVID. So HIV, then came HLH, and then came COVID. Inflammation storm. Cytokine storm happening like that. Multi-system inflammation in children. Happening 2, 4 weeks, 6 weeks later. So again, the concepts are the same. There is no change. And from that we learned a little bit, and then probably COVID will get us wiser and more in treatment of these things. So that the other day there was a patient we were treating. Somebody asked me, what did I do? He said infection induced inflammation. This is diagnosis. You have to understand the concept. You can't diagnose organism with diagnosis. How do you diagnose? Information once it has been produced, you have to treat the information. You can't be writing on this action negative or something. How will you? So conceptualization is more important than, and the patient is most important. Phenotypically, patient will be there. Some other things are. Once they are not there, then what will you do? So now we have, since we have handed over the baton to the younger generation, you have the younger generation. So it is important for you guys to take it forward, keep thinking, keep learning, and produce results. So now you have smart people around, you can think more, you can deliver more. You should be acting fast rather than waiting, not waiting. Not waiting. I waited for 25 days. Any comments?
I think I think this is something which everyone should take as a self-examination. So I think we remove so many different concepts. This And I think we need to periodically reinforce these in various platforms, various discussions, so that we can actually have a translation and value to be discussed in this last 1 hour.
What test we are doing?
So the genetic test, we have facilities for doing whole exome, whole genome sequencing, including testing for somatic mutations, which are often the cause in a lot of undiagnosed patients like that. So we can go basically genetic testing at greater depth, even at 250x. So the more we increase the depth of genetic testing, the more we are likely to pick up less common or less frequent variants, which might actually be leading to the.
So again, it is the sincerity of residents to remain in what for a longer time. Doesn't mean that you have to remain in the what. It is you have to keep thinking. You have to keep linking and reading and then discussing with people amongst yourself and then discussing with the people and then coming to these cases would have remained unattacked. So it is again a message to the mob.
Near diagnosis also.
So investigations again,
With clinical.
every patient cannot be getting. So it is the clinical. I'm playing it down. The genetic testing part. Sometimes even after genetic testing, you get anything which is related, but patient will not get anything on genetic part. They don't have.
Like now available.
So it is there. It is, but again, we have to move forward. But we have to clinical methods, clinical examination, repeated history taking. One of the patients, it was third history when we came to know about that she had tuberculosis sometime back, and then we found out. So we have repeated history taking, repeatedly going back to the same patient, repeatedly taking out some time for a history. So this is the moment. Any comment? Adil? Any other comment from residents? So, I'm really thankful that I've been in this, because the concept of inflammation, infection, and medicine I developed from Saudi. So, when I joined medicine, first I thought, so initially I knew, I laughed, I do medicine, what is this? So now in a span of last 10 years, I can say that this concept has really grown up. And I'm really strongly back because if that cell become medicine, we residents, psychologists, we are not really giving your heart and your hyperdynamic approach bedside. You really don't do those patients. Because it's just a bit of your thing of the head. If you are really citing your patient on hourly basis, times of 4 times a daily basis, this very cut of getting a patient class, not doing right, the people doing. So like Trump said, if you are wanting your patient on hourly basis, being bedside as much as you can, with simple clinical maneuvers of seeing vitals, and then with having these 3 or 4 basic investigations, can really catch what is the time when you need to be very intensive with modalities of therapies you have. That's the time when hit hard and can get patients out of this storms or gross information. So thank you very much. So the only message is that you be bedside, you try to be bedside as much as you can. These patients are crashing, try to catch them early so that you can hit hard. Thank you for excellent presentation.